Next up on the programme, to follow this act, we have a talk called Caring for Survivors of Hodgkin Lymphoma. It really does take a village, from Larissa Nekhlyudov. She is a professor of medicine at Harvard Medical School and a practicing internist at the Brigham and Women's Hospital in Boston. She's clinical director, internal medicine for cancer survivors at the Dana-Farber, where she offers clinical care for long-term survivors of childhood and adult cancers. She is particularly interested in improving the care of cancer survivors and the interplay between primary and oncology care. She's been at the forefront of cancer survivorship field nationally and internationally, leading and participating in the development of survivorship care policies and clinical guidelines, educational programs and research. Throughout her career, she has been committed to educating and empowering cancer survivors and their caregivers. Here is another extremely experienced and forward-thinking doctor to speak to us about survivorship care. Please welcome Larissa Nekhlyudov.
I don't know how I didn't recognize the fact that I was following you when you shared the program with us. Wow. Well, thank you so much for the invitation to speak to you today. I am so honored and privileged to be here with you all today. And lucky for me, I actually decided to share my time today on the stage with another patient, another survivor named Janice, who is probably, or who was known probably to some of you here in the audience. And I have a video that I will share that we put together actually in January of 2020, right before the COVID pandemic. So you will hear from me sort of a more kind of clinical academic talk, but I think that Janice's story will really bring this home. So with that, so you've heard from Emily about cancer survivorship and cancer survivorship care. So there are several aspects of cancer survivorship care. So as you know, as you're going through cancer treatment and you see your oncologist, oftentimes the focus is on the cancer, and is the cancer returning? Is there a relapse? What is going on? But really, there are many areas of cancer survivorship care. And so in Hodgkin survivors in particular, while we do still focus on recurrences and new cancers, for Hodgkin's, as you know, once that Hodgkin is cured, it's not over, right? And why is this advancing by itself? But there are many treatment-related cancers that may develop over years and decades. And so as a result, you may not just need your Hodgkin doctor. You may need your breast oncologist, radiation oncologist, surgical oncologist, a dermatologist if you had skin cancer, endocrinologist if you had thyroid cancer, ear, nose, and throat doctors if you've had head and neck cancer as a result of treatment. Okay. That's not. Pulmonary, gastroenterologist, primary care, and so many others. In addition, we need to focus on the physical effects. And here, once again, we have the need for so many other clinicians to be involved, including primary care, medical specialists such as cardiologists, pulmonary, gastroenterology, and others, as well as rehabilitation clinicians, physiatrists, physical therapists. We know that there are many psychosocial effects that develop as a result of cancer and its treatment, like fear of recurrence still, and anxiety and depression and sleep problems and sexual dysfunctions, among others. And so these psychosocial effects, which are often disregarded and brushed aside, really require the care of primary care clinicians, mental health providers, financial counselors, vocational trainers, and others. But really, cancer survivorship care cannot just focus on cancer care alone, and we really need to look at holistic care. We need to focus on lifestyle factors, tobacco cessation, vaccination, and that includes many more clinicians, including primary care, gynecology, dentists, dermatologists, and others. And then, of course, I apologize for that. And then, of course, other conditions that may have had nothing to do with the cancer or its treatment that also needs care, including primary care and multi-specialty care. And so really, if you look at the number of clinicians and healthcare professionals that a Hodgkin survivor may encounter, it's countless. It's countless. And so the question is, how do we train and how do we educate the clinicians that Hodgkin survivors interact with to be aware of the needs of Hodgkin survivors, right? They can't look at you as just another patient. Oh, you know, it's a 40-year-old healthy patient, you know, it's fine, like, you know, your shortness of breath, it's fine, don't worry about it. You know, your dental issues, that's fine, we can just do with the extraction, no problem there, right? We need to be sure that the multitude of specialists that you see are aware of your prior history of Hodgkin lymphoma and the types of treatments that you had that may change the way they approach you, the way that they treat you clinically as well. And so the other piece, and this is a slide that I always borrow from Shelley Feldnasso from NCCS, is that the cancer care is complex. And this doesn't even take into account the numbers of clinicians that somebody with Hodgkin's will see. And so there are multiple healthcare professionals and others that you will see. And so how do you navigate the care that you need in this terribly complex medical system of ours? And we'll chat a little bit about that during the Q&A. And so what can we do? What are the tools that we have? And so there is, you know, some of the areas are circled here is the cancer care delivery system. And so what I always say to, when I give talks to a cancer center, is that a cancer center cannot advertise that they have cured cancer if they have not prepared you for another cancer that you may be at risk for, if they have not prepared you for and help to prevent the cardiovascular disease that you're going to have as a result of your cancer treatment. So cancer care delivery systems have to do better. They really have to acknowledge that the treatments that patients have will have an impact on their future life and their future health care, and that is a responsibility that they have. You know, the other piece is, you know, we need to empower the communities and have community navigation programs. So recently there's now been an act that provides funding for cancer navigation. And so these are individuals who might be nurses, who might be social workers, who might be lay people, who work in the community, and they try to build bridges between community resources and academic and clinical resources to make sure that you don't have to travel from Maine to Dana-Farber to get the care that you need, but that you're able to have the care that you need and the resources that you need in the community. There is a need for primary care and specialty care professionals to be educated, right, as I already mentioned, about the physical and psychological needs of cancer survivors. And so there are those of us in primary care. In fact, Emily and Kevin and I are all actually primary care clinicians who are experts in survivorship. But there's not a need for many of us. There's a need for some of us. so that we can continue to educate patients in the community, educate patients and primary care clinicians in the community, and that we can take care of high risk, what we call high risk cancer survivors, so survivors who are at risk for late and long-term effects of cancer treatment. But really, you just need community primary care providers who just have like a basic understanding that if somebody comes in and they say, I have a history of Hodgkin lymphoma, they should be equipped to ask a few additional questions. And the few additional questions are, oh, when were you diagnosed? How were you treated? Did you receive radiation treatment? Where was your radiation treatment? Did you receive chemotherapy? Do you have any idea of the types of chemotherapy that you received? Did you get surgery? Oh, and did you get splenectomy? A few questions, and that's like all we really need for community primary care clinicians to be able to ask. And then, depending on the answers, they should be equipped to know that they might want to refer this patient to another facility, and we'll talk a little bit about that as well. So the other piece is we need community stakeholders, right? And this is, Emily suggested this during her talk, that the National Cancer Institute Office of Cancer Survivorship developed in response to advocates, to patient advocates who said, we have to do something about this. And so you all and your communities have a voice, and it's important that we work together to figure out how we can improve the care of cancer survivors in your community. And then, of course, community-based organizations that should provide specific cancer survivor-specific services. And so, again, some of the services may have to be at a cancer center or an oncology practice, but many services don't have to be in the ivory towers that some of us work in. And a lot of the resources, the mental health resources, the physiatry, rehabilitation, other resources can all be within the community. We're also now living in the post-COVID age, although I think one of our speakers may not think it was so post, and she's not here today. But what I meant is in the post-pandemic, in that we have Zoom, right? There are so many resources that are available online now that either were available online, but we never accessed it, or are newly online. There are numerous exercise programs that are available online for cancer survivors. There are psychosocial programs that are available online. And so it's important for us to kind of be there and disseminate these programs, and I think that that's where you also, as survivors, can play a role in making sure that you talk to your friends and neighbors and let them know about the resources that are available. And so with that, I am going to turn to Janice, and she will share some of her experiences. So Janice was a patient of mine, actually, in primary care, and for many, many years. And she was probably one of the first Hodgkin survivors that I took care of. And she taught me a lot. And through the years that that I was privileged to be her doctor, I learned a lot. And I'm so grateful that she agreed to do this interview that I wanted to do with her, because I wanted to use this interview with her to use as a teaching tool. And I have now shared this video with medical students, with residents, with primary care clinicians, and I think more so than anything that I can say, Janice can say much, much better. So we'll play the video.
I was a high school student, really good student. I loved school. By the time school started in September, I'd been to doctors all summer. I had this terrible cough, non-productive cough. My mother was walking to the grocery store and saw that this doctor was opening an office. And she was so desperate that she just walked in off the street and said, I need to make an appointment for my daughter. And he was the first person to do an x-ray. And what he told me was, he said, you have to go in the hospital tonight, you have a collapsed lung. What he didn't tell me was the lung was collapsed because the tumor was the size of a football. I was in the hospital for a month. They diagnosed me with Hodgkins lymphoma. So we decided to take the new chemo and radiation, and I've been in remission, what they call remission, ever since. What they told me was going to take about 2 years for me to feel normal. So I was able to live life as if I were a teenager, but when I went to college, I couldn't do it. I'd miss class because I just couldn't walk across campus. I thought, well, it's been 2 years, I'm supposed to be normal now. I wasn't. And I had follow-up care, but it really wasn't adequate. I had doctors telling me, it's stress, it's anxiety. A lot of problems were put down to being emotional. And I just wanted answers. And I don't tend to be a hypochondriac, but my doctors began to treat me as though I were. And it turns out that every single symptom I had was a late effect. There were years when I was actually trying to get out and live my life and go back to school and work, where I would get bad illnesses. It started getting really bad in my 30s and 40s because that's when the late effects that were kind of elusive were coming on. Those years, they were really frustrating because I had gotten to the point where I thought, nobody's ever going to figure out what's wrong with me. It's limiting me in living my life, and I'm just not going to get any help. I think the problem is there hadn't been protocols developed for what kind of follow-up you should have. And the doctors weren't seeing enough of this one type of patient to recognize certain things. At my late effects clinic, they said, oh, we see that a lot. And I burst out crying.
Janice's story is not atypical for an adult survivor of childhood cancer. She was cured, but years later she started developing late effects. Late effects are particularly common for childhood cancer survivors. Studies have shown that 60 to 90% of childhood cancer survivors will have some form of a chronic medical condition that resulted due to their cancer or their cancer treatment. The longer a patient survives after cancer treatment, the more likely they are to experience the late effects. She got married, but she really felt that she was not able to be the kind of wife that he married.
We got married in '94. Our first Christmas, he gave me hiking boots. I mean, we're very, very active, physical. I'm not that anymore. So one of the things I had to do is tell him, you need to still go out and do things. And it was really hard for him to do that. And we went to the cliff walk, and it got really steep, and there was a bench. Okay, I can sit here, I want you to go on the walk. Are you sure? Go take a picture for me, to get him to go. And that's been hard because I'm so limited, and I'm a very different person than he married. So we haven't had a problem. I mean, we've stayed very happy, but there are times I think, I'm sticking around here. He's gonna have a better life when I'm gone. And he says, no. But I feel sometimes like I'm such a drag. And you married a healthy woman who was employed and making good money and, had all this stuff going for her. And now basically I live on my couch. So I feel guilty about that. At that time, I kind of was getting the idea that I wasn't really healthy enough to go through any kind of pregnancy. But yeah, I lost my fertility to radiation.
How did that affect your life as a young woman, as a newly married woman?
It was awful. I mean, I wished that it hadn't happened that way. I wanted children. I didn't realize, like, with my health issues, I had some self-loathing. Like, I don't know how I kept turning it all inward, but I was really just like hating myself. And I didn't really understand it. So it would have been nice to address that as we went along, because it was not part of any treatment. I was diagnosed in 1977. It was when employers could still ask you if you had cancer. And people did not talk about it. I was told, do not tell anybody you've had cancer. You won't get a man, you won't get a job, you'll lose friends. And I'll tell you what, all of that happened. All I knew was that you get cancer and you die. I had no idea if people could survive it. You know, it wasn't something you talked about. So I said, well, I'm gonna talk about it. I want people to know. Then felt like, well, I can't just say, you can have cancer and you can live and look like this and be a dish rag. I need to be healthier. And so I wanted to be super survivor. Well, yeah, because we want people to know there is life after cancer and it can be a good life. But then when I started having late effects, and particularly when they weren't understood, they weren't acknowledged, it was like, now I'm fighting to say the opposite. And that was really hard. That was a big question of identity for me. I have people that find me on social media and they're recognizing symptoms and saying, I think I have that. They're not getting this from their doctor. It's so frustrating to still see that now, because I remember just feeling absolutely desperate. I am never going to get any help. I do know it is somewhat better. There are more late effect centers, but it's not where it needs to be at all. I mean, I definitely think that every doctor needs to understand what late effects are and be willing to work with experts. There just needs to be better recognition of how impactful all this is.
If somebody had a history of cancer, we need to get more information. We need to look at the whole person. So that means that we in the community have to embrace the resources that are available, or cultivate resources so that the needs of our cancer survivors are taken care of. And as we do research and as we take care of our patients, it's important for us to continue to ask our patients about their experiences, so we may be able to learn and grow and help the future generation of survivors.
The word survivor. What are your thoughts about that? People love it, people hate it, people don't care.
I like it. I do, because it feels like what I'm doing. There's something almost very active about being a survivor. Because for me to have lived this long, especially when I was not expected to, I've had to do a lot of things to keep myself alive. So I wear it. I know some people don't like survivor. I like it. Because I'm surviving, and it isn't always easy.
I've watched that video I don't know how many times, and I always tear up at the end. So I thank Janice for sharing her insights. And Janice actually survived for a long time. And through the pandemic, she was mainly at home, and she was on palliative care, and she didn't want to die because she didn't want to leave her husband during the pandemic. And then ultimately, when sort of things kind of resumed, she decided that it was time to go. So thank you. So anyway, I will transition. When Erin and I first chatted, and she told me about this meeting, and I even at that point thought that it was just such a tremendous idea to bring this group of Hodgkin survivors and their caregivers together. As was mentioned in my introduction, so I'm both a primary care physician and also a survivorship physician at the Dana-Farber. And I see adult survivors of childhood cancer and also adult survivors of select adult cancers. And so it just happens to be that I see many, many, many patients with Hodgkin lymphoma. Dana-Farber was a big treatment center, sort of big back in the day. And then also we see people from New England. And oftentimes when I get a new patient who comes in to see me, the question that is asked is very often is, have you seen anyone else like me? And to which I respond, yes. But realistically speaking, unlike some other, cancers that unfortunately are very common in the community, and you can always see someone and know someone who had, lung cancer or breast cancer or colon cancer, it's not a usual cancer, it's not usual for a Hodgkin survivor to interact and see another Hodgkin survivor. And so I think this is just such an incredible organization and such an incredible gathering place. And I am so thrilled that all of you are here today. So thank you again.